pleural effusions. And I'm going to start with a few definitions because I thought, especially with this topic, the definitions were, they already gave a lot away of what the whole topic of pleural effusion is about. And after showing you two definitions, we'll go through the diagnostics, and we'll start by this very important distinction of Transudate and Exudate, and we'll get into the Lights criteria. But we'll also talk about, took some pictures from Amboss on all the equipment that you need to perform a thoracentesis, and I can talk you through that. And afterwards, we'll touch upon a few subtypes of pleural effusion. And finally, it'll be a smaller point, but the treatment, because the treatment, pleural effusions, we're gonna learn that there's so many different underlying causes of pleural effusions, so the treatments are going to be very specific. But I think I'll walk you through three general ideas of approaches to treating pleural effusion. So without further ado, let's continue to the definition. So, okay, definitions. So these are definitions that I found on the internet. The first one is right from Amboss, and it says, a pleural effusion is an excessive amount of fluid between pleural layers that impairs the expansion of the lungs. And then this other one, the Cleveland Clinic, is a very big, good clinic in the US, and their definition on their website was pleural effusion, sometimes referred to as water on the lungs, is the buildup of excess fluid between the layers of pleural outside the lungs. And what I thought was interesting, oftentimes definitions are very technical and they don't have these side sentences as sometimes referred to as, or that impairs the expansion of the lungs. It's already, the sentence that impairs the expansion of the lungs is already a functional description of what the pleural effusion's impact is. And I thought that was odd that that was already included in the definition. And that just shows you and reminds you of the fact that a pleural effusion is a degree change, because there's always fluid in the pleural cavity. I think it's like 7 milliliters. But when it becomes too much, then it becomes an effusion, and then it becomes a problem. And the problem in some cases is that it impairs the expansion of the lungs. But pleural fluid, pleural stuff in the fluid in the pleural cavity is normal. And when it becomes too much, it has effects, and that is the problem. So I just thought that was interesting, and that already sets the tone for studying pleural effusion, and that's why I thought it was worth taking a minute. So let's get into the approach to pleural effusion. So when somebody comes into the clinic, to the hospital, or to your practice, they're not going to say, I have a pleural effusion, I need treatment for a pleural effusion. They're going to come as a patient that you already know oftentimes, and they are going to have pre-existing conditions. There we go, mute. So they're going to have pre-existing conditions such as a heart failure, or such as some lung cancer, which is going to predispose them to forming pleural effusion. They might also be on medication that has a risk of creating pleural effusion. And a very important thing that will help you diagnose a pleural effusion is the timing of symptoms. I'm trying to mute. There we go. So if somebody comes in and says, if they're a known, for example, if they're a known heart failure patient, and they come in and they say, oh, I have a lot of dyspnea, then it's this increase in dyspnea within a very short period of time that should perk up your ears and make you think of, oh, this might be just more than pulmonary edema. This might be a pleural effusion. So it's very important to take a good personal history and think about all these various factors that can create a pleural effusion or contribute to it. And once you have a suspicion, you should move on to the physical exam. And there are a few telling signs of pleural effusion. So first of all, this is nothing to rely upon, of course, but inspection, they say that there's less mobility of the thoracic cavity, especially if the pleural effusion is only on one side of the thoracic cavity. So, but that's the following signs are much more important. So, palpation. When we're listening to lungs, we feel the lungs to see if they are moving, if there's adequate respiration. We put our hands on the thorax of our patient to feel, do they have proper respiratory movement? And a test we also do is called the tactile fremitus. And to do that, if you place your hands in the lower back of the patient, and if there's a difference in the feeling of the vibrations created by the patient talking, that means that there's something there. And in the pleural effusion is fluid within the pleural cavity that is around the lungs. And whenever there's something in this pleural cavity, it creates a barrier, and vibrations and breath sounds, everything that is created in the lungs cannot go through the pleural effusion and be heard by us. So the pleural effusion basically blocks everything. So when we're palpating, we have reduced tactile fremitus. When we're auscultating, listening with our stethoscope, we hear reduced breath sounds and reduced bronchophonia. When we percuss, the resonance that we hear is reduced, and very important, laterally rising. So think of the pleural effusion as this shield or barrier that disables you from listening to what's going on. You hear, feel less with pleural effusion. And a very important characteristic of a pleural effusion is the meniscus shape of the hyporesonance when percussing. So it is reduced and laterally rising like a meniscus. Later on, I have a picture of a meniscus so you see what I mean. Actually, we'll just go to the next slide right now because I have a picture right there. No, this is okay. This is a slide I put in for you to study. It is for future reference. We're right here in the pleural effusion category, and as I said, everything is decreased or absent, decreased tactile fremitus. Percussion is dull. Mediastinal shift is away from the effusion. That is not as important because it is very rare and the pleural effusion has to be very large. But I put this table in here so that when you go back and look at the slides that I'll send you later, you can review how a pleural effusion appears on these pulmonary examination findings in comparison to other lung pathologies. Okay, so we're going to get to the meniscal sign and the lateral rising of the pleural effusion in just a second. But so first we had the personal history, then we had the physical exam findings, and now we have great suspicion for a pleural effusion. And sometimes the next step is to do a chest x-ray or to do an ultrasound. And sometimes you have a patient who comes in, for example, with pneumonia, and you do a chest x-ray, because a chest x-ray is the gold standard to diagnose pneumonia. And then on the chest x-ray, you notice, oh, this patient has pneumonia, but also a pleural effusion. So sometimes it is a secondary finding, and depending on that you move differently through the diagnostic tree. So a chest X-ray is lots of pleural effusions are diagnosed within a chest X-ray. According to literature, the lateral recumbent is the most sensitive, but in practice on tests, for if you're still in medical school or afterwards in the clinic, most of the chest X-ray are standing, AP, PA, and they are in two planes. So you have this view and a lateral view of PA view. And the most important thing to look at in the beginning of a chest X-ray is to assess the recessus costodiaphragmaticus. Those are these tiny, and they should be sharp angled. So they should have an angle below 90 degrees. It should be an acute angle. And if these are blunted, so if the angle is not like this, but like this, that is a sign of pleural effusion. So let me show you what that looks like. And then I'll also get to my meniscal sign here in a second. Here we go. So these are images of a chest X-ray with pleural effusion. And I've drawn a few circles here so you can see what the important things are to look at. So whenever you're looking, I don't know if you've had a lecture on how to approach a chest X-ray. Actually, I think I saw that you have had. So you know all about making sure everything's on the chest X-ray, make sure there's no rotation, making sure looking at the bones first, and then one of your primary points in the beginning should be to see if these recessi are clear. And as we can see on the patient's right side, there's no acute angle here whatsoever. And on the patient's left side, there is a very pointy acute angle to this recessus. This is how it should be, and this is when there is a pleural effusion. And as you can see, the pleural effusion, though, you can see that the density increases and it goes up the further laterally you go. And you can, this line follows the pleural effusion, oops, and it is called the Elis Damoiseau line. Not important to know in practice, but sometimes it pops up on tests, and it popped up on my test. That's why I put it in here. So maybe it'll pop up on your test. But this is very characteristic of a pleural effusion, and it is meniscus shaped. And what I mean by this, if these are the this is the meniscus, these are the menisci in a knee. And as you can see, medially, they are quite low. And then once they go laterally, they rise right here. And this shape exactly fits right here if you were to make it bigger. So that's a good word and to know and something good to think about. And in the lateral view, you can see that it's not just a straight line across, and this is what creates this meniscus shape, is that there's still lung there. The pleural effusion is not in the lungs. The pleural effusion is in the pleural. It's between it's in the pleural cavity. So it's right here, and there we go. So this pleural effusion, especially when it's a transudate, which we'll come to in a minute. So when it's just this loose fluid that has the ability to get pressed up along the sides, it gets pressed up along the pleural cavity to the sides of the lungs. And that is why it doesn't collect in a straight line, but it has this curved shape to it. And you can see it in the lateral view too. It has a curved shape here, and it collects in the back here too, where there's within the pleural cavity. So hopefully that helps with diagnosing a pleural effusion on a chest X-ray. Let me move on to the ultrasound. This is a screenshot from a video on YouTube, and it's a very good video. because they have an overlay on it in a second. So, and the ultrasound is a very important tool for the pleural effusion because it is not only good and helpful to diagnose a pleural effusion if you have the suspicion after performing your physical exam, but it is also very, very helpful when treating pleural effusion by, for example, performing a thoracentesis. Because it can be done on the bedside seconds before you put the needle in to tap the pleural effusion. So it is usually done in the sitting position, the patient is sitting on the bedside. So the patient is sitting on the bed and you're on the other side of the bed, and you can put all your stuff on the bed to get ready for your pleural tap, and you apply the ultrasound to the back of the patient. It is very sensitive and it can pick up pleural effusions just above 20 milliliters in comparison to the chest x-ray, which depending on the position picks up pleural effusions after 100 milliliters or 200 milliliters have accumulated. And the pleural effusion is this hypoechoic area on the ultrasound. So it appears black, it is fluid, in comparison to the lung tissue, which all these alveoli and the bronchioles and the lung tissue creates this hyperechoic and very grainy picture, because the ultrasound is reflected on all these different layers. And this is I'm just going to say water right now. It's just liquid. It's just liquid, and that's why it is uniform hypoechoic area seen on the ultrasound. And in the overlay, this becomes very clear. So this is the effusion, this is the pleural line, and this is the reverberation artifact that is created by lung tissue. And this is that same costodiaphragmatic recess that I was talking about earlier, which should be acutely angled. And right here we can see, this is the part that we don't see on the x-ray because it is filled up with the effusion. So the x-ray that only shows the lung going until here. And this is not an acute angle. And that is how we know. If we see this angle on the chest x-ray, then we know something is filling up this acute recessus. And that is oftentimes an effusion. So I'm just going to go back and forth. So this is what it looks like when you're doing the ultrasound. Black, hypoechoic is the effusion. And this is the overlay from YouTube. Okay, so sticking with stuff that showed up on my tests that I think might be helpful for you, and is what does a pleural effusion look like on a chest CT scan? And so earlier, as I just mentioned, we had a meniscus shape on chest x-ray, and on CT with the patient lying down, we have sickle shape. This is a sickle. And I'm just gonna, which medication can cause this condition? Fluid. Okay, you are presenting host, so be careful. Please be careful. Okay. Sounds good. Okay, so it's sickle shaped. So sickle as in, it is at the bottom. In CTs, the patient is lying down. This is the right lung. This is the left lung. And we can see that the sickle-shaped pleural effusion is gravity dependent and in the back of the thoracic cavity, in the back area of the pleural cavity right here. So I just wanted to make sure that you guys remember that in a chest x-ray, it is meniscus shaped, and in a chest CT, it is sickle shaped. Those are oftentimes trick questions. Okay, so now to the important light criteria. And these are some of the numbers that you should definitely memorize. Most numbers you can look up and it's all good, but these are numbers that you should memorize. And the way I think about it, so there's two numbers that we want to remember, three numbers we want to memorize: 0.5, 0.6, and 2/3. And it's protein and LDH. So what we're comparing is we're comparing the protein in the pleural effusion compared to the protein in the serum. And we're comparing the LDH in the pleural cavity in comparison to the LDH in the serum. So if it is a transudate, then there is less than half the amount of protein in the pleural effusion than there is in the serum. So if there's 10 proteins in serum, then there is 3 in the pleural effusion, then that is a transudate. If there are 10 proteins in the serum and there are 7 proteins in the pleural effusion, then it is an exudate. If comparing the LDH, if there is 10 units of LDH in the serum and there are 5 units of LDH in the pleural effusion, it is a transudate. And if there are more than 6, so 7 or 8 units of LDH, and the patient has 10 units of LDH in its serum, then it is an exudate. And there are 2 measures. I just remember LDH sounds worse and is worse. Whenever there's LDH around, that means cells are bursting and things are breaking, so it's bad. LDH is always bad. We don't want high LDH. So that's why LDH has the high numbers. It's bad, it's big. So LDH is bad. It has 2 numbers, 0.6, 2/3 of the upper normal limit of the normal serum. And it is the higher numbers. So protein is fine, 0.5 is the cutoff. LDH is bad, 2 cutoffs, and they are both higher. They are 0.6 and 2/3. So those are just numbers that you need to know. And when you're on rounds in a hospital with your attending, this is a very popular question because it lays the groundwork of how do we approach this pleural effusion. Is it a transudate or is it an exudate? Exudate is far worse, and transudate, not good, but could be worse. So the main causes of a transudate are congestive heart failure, cirrhosis, and nephrotic syndrome. And everything else usually causes an exudate. This is malignancy, TB, parapneumonic, fungal, empyema, and pulmonary embolism. So this is a table that you should memorize and know by heart. And that's why I put it in here so you can study it later. And it's very important because it gives you the approach to which path we're going to go down for this pleural effusion. So the idea and what it means, transudate, exudate. Transudate means it just goes across. Trans. It just, the water or the liquid, the lymph, it just goes across because of increased hydrostatic pressure or because of a decreased oncotic pressure. So the decreased oncotic pressure is what on the previous slide was the hypoalbuminemia, which results from cirrhosis, the liver produces albumin, or nephrotic syndrome, which is when we have proteinuria. So if we have nephrotic syndrome or cirrhosis, it decreases our oncotic pressure. That is also why we have edema, pretibial edema, and stuff like that. That is because of decreased oncotic pressure. And that is also why we would have a pleural effusion in those cases. Or, for example, in congestive heart failure, congestion leads to increased hydrostatic pressure, and that is a transudate. On the other hand, all the bad things, TB, malignancy, pneumonia, all these bad things, they're bad because they're not nice to our vessels. They break our vessels and make them leaky, which leads to all this good stuff going to places where it shouldn't be. Our red blood cells, our white blood cells, the protein, LDH, all that stuff is leaking out of damaged capillaries and lymph, small lymph vessels. And this is called an exudate. An exudate, because there's a lot more stuff, exudate is not clear. It is often cloudy or yellow, straw colored, all of those descriptions. And transudate is clear and better. So I hope this slide helps you understand transudate versus exudate and gives you a picture in your head. So comments on left versus right effusion. This is also important to think about. If you have a patient and they have a pleural effusion on one side of their chest, if it's on the right side, it's better, and the left side is worse. Because the right side, the right pleural cavity, has a decreased intrapleural pressure. So that means if it is just a congestive heart failure issue, for example, with the fluid, being congested back, it'll first go out into the right pleural cavity and then into the left. So right first is good, but if it is left first, if the left pleural cavity has a pleural effusion first, that is a sign that something more serious might be going on. We might have a malignancy, or we might have pancreatitis seeping in through the diaphragm, for example. Those are more serious causes of pleural effusion, and they often originate or present themselves on the left side first. So what is thoracentesis? Thoracentesis is diagnostic and therapeutic, which is very important to know, because in some cases it has therapeutic value, and in some cases it's diagnostic. Sometimes people think it is just diagnostic, but also it's both. At the end of the day, it's both. So it's diagnostic and therapeutic. So a few key things that are important about thoracentesis that I will go into the contraindications in a minute, but a very popular question by attendings and very important thing to know and to remember, which you might have learned while you were learning anatomy, is that the vasculature and the nerves, they follow the bottom of the ribs. So whenever we put in a chest tube and perform thoracentesis, we always take the needle. I'll demonstrate this right here. We take the needle, we hit the rib, and then we slide over it to make sure that we're getting right on top of this rib and not below. Below is the good stuff. We don't want to hit the good stuff because we might cause, for example, a hemothorax or something. We always want to hit the rib with our needle and slide over it into the pleural cavity. Another important thing to do is, if somebody has a large pleural effusion, let's say 2 liters, you shouldn't take 2 liters out at once, because the lung has been compressed by this large pleural effusion for quite a while now. And if we were to take out 2 liters all at once, they can lead to something called a re-expansion pulmonary edema, or re-expansion syndrome. It is a self-limiting, non-cardiogenic pulmonary edema that develops within 24 hours of rapid re-expansion of lung tissue. So as I mentioned, if we take out 2 liters, if we take out a lot of pleural effusion at once, the lung rapidly expands, and this can cause a non-cardiogenic pulmonary edema. So that is just something to watch out for. And if the attending asks you, how much pleural effusion should we take out at once? 1.5 liters, never more. So these are a setup. This is what I was mentioning. The patient is in the sitting position. You have your ultrasound right here. You find the pleural effusion. Let's say the pleural effusion goes up to the 5th rib. Then we should puncture the pleural effusion around the 6th or 7th rib. You shouldn't go below the 8th rib usually, but find the upper limit of the pleural effusion and go about 1 or 2 ribs down. And remember to go on top of the rib And this is the stuff you will need. I'll get into the tubes later. They're very important, but this is some disinfection stuff, disinfection spray, a disinfection swab, and our cloth that we're going to put around, and our syringes, some local anesthetic, and a bag which is marked so that we know how much we're taking out, because we don't want to take out more than 1.5 per lung. Okay, so this is just a picture. As I said, we go above the rib. We have our needle. It's kind of like an IV access. It's basically the same thing. You can use an IV access to perform a pleural tap. So you go in with your needle, and then you remove the needle, and you just have the catheter in place. Attach it to the bag, and then you can measure how much you're taking. This all depends on what kind of equipment you have, but this is a general idea of the procedure so that you can visualize it for those people who haven't seen it in person. I'm just going to check the question box. Vein, artery, nerve. Yes, van. Exactly. Van. Perfect. Rib, at which level, which conditions? One, yep, vein, artery. Okay, perfect. Van. Very good. So contraindications. When do I not perform a thoracentesis? I do not perform a thoracentesis if my thrombocytes are less than 50,000, or if my quick is under 50%, or my INR is over 1.5. Basically, when the patient is at risk at bleeding too much, because I could cause a hemothorax. And that I don't need to add that to what I already have. So these are contraindications. These should be remedied before, ideally before performing a thoracentesis. And once I'm in the pleural effusion, what do I take out? I always try to take 3 syringes. I take 1 sterile syringe and try to inoculate the normal blood culture set to see if anything grows, any bacteria grows. I take 1 syringe and send it to the clinical chemistry for my light criteria definitions, LDH, protein. I also want to figure out cell count, which is important, for example, with TB, because in TB, I want to have a differential cell count so that I can distinguish a lymphocytosis from a normal leukocytosis, glucose, pH, triglycerides. So 1 tube to microbiology for the bacteria, 1 to clinical chemistry, and the last one to the pathology to see if there are malignant cells in there, for example, with lung cancer. What can happen? What can a complication of a thoracentesis be? I can cause a pneumothorax, and that can be very dangerous. So if possible, I rule that out with an X-ray a few hours after performing the thoracentesis. Or if I wait 4 hours and the patient has no symptoms, I can feel good about not having caused a pneumothorax, but it would be best to rule it out with an X-ray. So depending on the cause of the effusion that I've determined with my 3 syringes, and after thinking about the lights criteria, I have to order different follow-up tests. For example, if the effusion is very red, then I'm thinking, okay, there's a lot of blood in here. This might be a hemothorax. Then I should get an HB on my patient to see if he's anemic or if he needs a transfusion, for example. So these are the contraindications of thoracentesis. Remember, 3 syringes and don't cause a pneumothorax. So what are the subtypes? I just mentioned hemothorax. It would have a bloody appearance. The red blood cell count would be above 5,000 per microliter, and I would find a decreased HB in the serum. The most common pleural effusion is parapneumonic effusion, which can lead to empyema, and I'll get into that on the next slide. I mentioned malignant pleural effusion from cancer. This would be cloudy or straw colored. I mentioned TB effusion and the differential cell count, which would show lymphocytosis. And further, this is a very rare, but this is for the medical students, this is a chylothorax. which is usually caused by the doctor and is very rare. And this is the reason I determined the triglycerides on my pleural effusion tap. So this is for the tests, and this is for real life, the parapneumonic effusion to empyema evolution. So the evolution of infection I wrote down, because if we see here in the characteristics of these different types of pleural effusions, it goes from uncomplicated to complicated to empyema. Uncomplicated is without direct bacterial invasion. Complicated is with bacterial invasion. And then invasion turns to colonization. So this is proliferation. And for those who don't remember the definition of empyema, empyema is pus within an already pre-existing body cavity. So the pus didn't form this cavity, it is just collecting in an already existing cavity. And along with the evolution of infection, the pH decreases, glucose diminishes, same as in a cerebrospinal fluid tap. If we have meningitis, the glucose is low, the pH is down, LDH is up, and it appears more cloudy the worse it gets. So in the beginning, uncomplicated, it is slightly cloudy, then it becomes cloudy, and then it becomes purulent, which is proliferation and colonization. At the end of the day, though, this is all caused by pneumonia, parapneumonic pneumonia, infusion, and each one of them is treated with antibiotics, and depending on the degree of invasion and colonization, we have to add a chest tube or, for example, a VATS, which I will come to in a minute. Okay, yes. Okay, we'll go into the re-expansion later. Okay, so the treatment, and this is coming to the end of my presentation. So pleural effusion can have so many different causes and there's so many different things that can cause a pleural effusion. I only mentioned 5 or 6, and there are probably 20 or 30 out there. But the most important ones I think I mentioned. So for example, heart failure or pneumonia. Heart failure, you can initially try to just treat with diuretics, which is the mainstay of heart failure exacerbation therapy. And this is an exception to the rule of tapping upon diagnosis. Usually whenever you have a pleural effusion, you want to perform a thoracentesis to figure out what kind of pleural effusion it is. But if you have a patient who is a known heart failure patient and he is presenting with the physical exam findings of pleural effusion, then you can try to just treat that with diuretics. If your patient has pneumonia, you should tap it and make sure it's a parapneumonic effusion and treat the pneumonia and the effusion with antibiotics. Thoracentesis, as I mentioned, is diagnostic and therapeutic. For example, in pneumonia, it is an infection. Pneumonia is the infection. It can result, I think 5%, I know, 5% of pneumonia result in a pleural effusion. And because it's an infection, we can treat the infection with antibiotics and the infection will hopefully go away. This will be a 1, maybe 2 time thoracentesis with which we can treat this pleural effusion. But there are other causes, for example, malignancy, that can cause ongoing pleural effusion creation. And so these patients sometimes have an indwelling pleural catheter, which you can tap. So I remember a patient, he had 2 pleural catheters, each pleural cavity, and every 2 days I would go and hook up a drainage and take out 1.5 liters out of each lung. And I did that every so often, every few days. So that's in the case of malignancy, for example. If I was talking about the evolution of the infection earlier, and sometimes the pleural effusion can result in these fibrin deposits really contracting the lung, making it very hard for the patient to breathe. And it is these fibrin deposits, they won't disappear just by tapping the pleural effusion. So in those cases, it is necessary to invasively get into the chest and perform a video-assisted thoracoscopic surgery with debridement of these fibrin deposits. Yeah, I also saw that once, and the surgeon was just peeling off these deposits, and you could see the lung just blow up, and you could only imagine how relieving that must be for the patient. So depending on how long this pleural effusion has existed and how serious it is and how chronic it is and how many deposits, the more invasive measures need to be taken. So that was my last slide, and then I have some questions here to review. Afterwards, when you're studying, what test do you order if thoracentesis yields red fluid, and how many syringes do you fill with pleural tap fluid? But I'm always open to your questions after the lecture, and that concludes my lecture for now.